Welcome to Clinical Learning Reimagined, the podcast for health professions educators who believe that improving clinical learning from the beginning is a passion worth reimagining. I'm your host, Dr. Leslie Fall, founder and CEO of Aquifer. Each episode, I sit down with a boots-on-the-ground clinician or basic science educator and thought leader, visionary innovator, or leading researcher who saw an emerging problem or need and courageously started to address it, asking hard questions, testing long-held assumptions, and pursuing bold new ideas and building towards something better for all of us during the most disruptive times our field has ever seen. These are real conversations with people working at the forefront, the ones I believe are best positioned to help us envision the way forward and build on their work. So, pull up a chair and let's reimagine together. Welcome back to Clinical Learning Reimagined. Today, I'm continuing my conversation with Dr. Michelle Daniel, Professor of Emergency Medicine at the University of California, San Diego, and Vice Dean for Medical Education there. If you missed part one, be sure to go back and listen wherever you get your podcasts or on YouTube. So I think one of the other frameworks that you spend a bunch of time talking about, and another near and dear, to my heart as well, is this idea, of a master adaptive learner framework, which emphasizes self-regulated learning and a personalized approach to competency development. But one of the things that you wrote about that I love the best, because I don't think anybody else really talked about this, was the approach of looking at educators and the learning environment itself. You wrote that educators themselves need to be adaptive, flexible, and able to grow with the learners themselves. COVID kind of got us practicing, and now AI is really expecting us to do this, as well. So I'd love to just take hear your take, whether it's AI or not. What does an adaptive educator look like to a learner?
Yeah, again, it's complicated. So I think clinical reasoning, it's such a great example of why it's complicated. And the deeper that I've gone into studying clinical reasoning, I think the more humbling it's been. And I thought I understood pretty early on, basic clinical reasoning processes. I'd read Daniel Kahneman's Thinking Fast and Slow. I was like, okay, I got this. But then it just got more and more complicated. And I think my work over time has reflected that as we layer in other cognitive theories and situational theories and expertise development. And now let's think about assessment and programmatic assessment and how context changes things, and now technology and AI. And so I think that experience is important because most physicians are learning med-ed, as we talked about, on the side. And they can be excellent clinicians, they can be excellent teachers, but then they're also seeing patients, supervising trainees, doing research, leading programs, and managing all the other demands of academic medicine. So when we say, here's the evidence, here's the theory, now go off and happily redesign your curriculum around it, that can be a really large ask. And so I think the gap between what we know and what we do is it's really a translation problem. And so we have sophisticated theories and a growing evidence base, but actually translating those into something that's usable in a real education program takes time, expertise, and usually a team. And I think that one really surprising barrier is that we sometimes underestimate the expertise that's required to do that translation well. So like that master adaptive educator.
Yeah.
And so there can be this tendency in medical education to think that because we're experts in medicine, we can be experts in education too. And so I certainly thought that way earlier in my career, and then got very humbled. Because, as we talked about, education science is a field. It's got its theories, its methods, its own language and evidence base, and developing depth in it actually takes time. And so for me, one of the biggest lessons has really been that curiosity and intellectual humility. And so if you're trying to solve an educational problem, as a master adaptive educator, you should go to the literature and ask what is already known, and then be willing to discover that the problem could be more complicated than you first thought it was. And equally important, don't be afraid to bring in people who know things that you don't. I think some of the most interesting work really happens when you deliberately build teams with complementary expertise.
Yeah.
And the work that I'm doing right now around AI and clinical reasoning is actually a perfect example, because we have people who understand AI at a very deep technical level. And then we have people who are frankly theory wonks like me about clinical reasoning and learning. And those are very different forms of expertise.
Yeah.
And the magic's kind of in putting them together. And the AI experts see possibilities that I would never see. And those of us who are steeped in clinical reasoning theory are, asking questions about learning and cognition and expertise development. And, well, what are the unintended consequences of doing that thing that would otherwise come up? And so I think that kind of collaboration prevents us from solving the wrong problem elegantly. And so when you ask about what it takes for educators to be adaptive educators and teach differently, I think the first step is not telling people, hey, here's a new model you need to adopt. It's actually helping them understand why their current approach may not be sufficient. And so trying to make that problem visible. And if educators can see that a learner who gets the right diagnosis might still have a fragile reasoning process, or that an assessment maybe only gives them a narrow window into reasoning, and then theory stops feeling abstract, it becomes useful. And that's where I think the buy-in begins. And you help people see that theory isn't there to make education more academic or more complicated. It gives us a way to understand what we're seeing and to design better. Then you also have evidence to help you avoid reinventing the wheel. And so then it becomes a question of, well, how do we make that expertise accessible? Mm-hmm. Because not every clinician educator needs to become a learning scientist, but every program, every school needs people who understand educational theory and evidence deeply enough to translate it into practice. And so that might mean faculty development or bringing in education researchers. It might mean creating interdisciplinary teams to design curriculum. But I think it is really recognizing that educational design itself is a form of expertise. And once you recognize that, then expectation changes. And instead of asking every individual faculty member to be a master of everything, mm-hmm. build systems where people with different strengths can contribute. And so I think that's probably the most realistic path forward. We're not going to get broader adoption of sophisticated approaches to clinical reasoning education by making every educator read hundreds and hundreds of papers.
Please, no. We don't have a lot of people out there who really don't want to do that. But, it's an interesting thought, though. I mean, we think about, the ability of AI to help us in all kinds of areas. What are sort of your thoughts about, as an educator, leveraging AI to sort of help you be better at your own job? Help you be better at taking some of these, like you said, theory wonk. It's easy, when you're a clerkship director to go, well, that's all great, but, I've got, rotations full of learners. I'm also seeing patients, I've also got to worry about the residence experience with my learners. I mean, you practice and you're in this environment as well on a daily basis. What are your thoughts about how an educator, I'm sort of thinking maybe about a clerkship director or a program director who's been kind of in that role for a year or two, is wanting to do the right thing, has theoretically access to all this knowledge, may not have really the resources to pull in all these, AI experts and everything else. Maybe their school's a little behind in getting up to speed. What would you recommend, or have you recommended to sort of young educators who are willing to lean in potentially and use AI? How could they use AI to help them in some of the things that you're talking about?
I mean, a lot of our educators now are having AI develop a foundation for them for question writing, for example, or for, even, I think one of the most valuable and underutilized assessment methods in clinical clerkships is something like chart stimulated recall, where you could actually take a learner's chart and, feed it into a HIPAA compliant version of AI and say, hey, help me walk a learner through a chart stimulated recall process here. Tell me what you were thinking about when you asked X. Tell me, what was in your problem representation at this point in time that made you order lab test X, Y, and Z. And that it could actually facilitate, I think, some of the coaching and learning that would be really ideal in the clinical setting that right now we sometimes feel too busy to accomplish.
Yeah.
And so even just that ability to cognitively offload for the educator of saying, hey, help me develop the right questions to probe this learner on their reason would be an example.
Yeah, no, I think that's a great idea. And again, to your point about collaborating, sometimes the AI in and of itself, may be a little bit your own collaborating, partner as well. Given your broad perspective, I'm going to hand you my reimagining magic wand. And thinking through a lot of your answers today, if you could really redesign medical education or health professions education from the ground up, what would be fundamentally different about your model?
I think the most fundamental change would be to really stop organizing education primarily around what we want to teach and start organizing it around how expertise actually develops. And that'd be a huge lift.
Yeah.
But
remember, you have the magic wand. It's okay. Keep waving.
Yeah. So I feel like right now, medical education is still largely structured around courses and clerkships and blocks of content and discrete assessments. And we teach something, we test it, the learner moves on, and we hope that all of those pieces magically integrate somewhere into competent clinical practice.
Yeah.
But expertise doesn't really develop in neat curricular compartments. It develops longitudinally through repeated exposure, through increasing complexity, through deliberate practice, feedback, reflecting, and then adapting across different contexts. And so I would build a system around that developmental trajectory. And I think clinical reasoning really should be one of the central organizing constructs, not something that's just taught in a clinical reasoning course or in a few sessions or, assessed here and there on our exams, but actually some things learners develop and revisit continuously. And early on, I think we have to give learners a really strong foundation and help them build illness scripts and knowledge structures, which require, retrieval practice. And we have to make those connections between basic science and clinical care explicit.
Yeah.
Because we know that those connections aren't going to reliably happen by themselves.
Right.
And then as a learner progresses, they would encounter increasingly complex and variable cases. And we deliberately ask them to explain not just what they think, but how they're actually thinking and get at their metacognition, that making reasoning visible. An assessment would look very different. So instead of asking whether a learner passed a series of isolated multiple choice question assessments, we'd actually be collecting what Sace van der Vluten calls the 1,000 points of lights, like those multiple observations across time and settings and methods and observers. And we now have technology through dashboards and things that can make all that data visible to make decisions in a way that we never had before.
Right.
And so, some assessments would still be standardized and they'd sample broadly. Great, MCQs still have a role. Some would be simulation based, but the vast majority of assessment and better assessments need to happen in the workplace.
Mhm.
And then where everything's contextualized. And then, rather than treating assessment as all these independent judgments, we look for patterns across them. And the questions become, what's the trajectory of this learner's development? Where are they strong? Where are they struggling? And what experience does this individual person need next? Because that's actually one of the coolest things I think about AI that we haven't talked about is we now have an ability to know in the clinical setting what every learner has actually seen and encountered if we build the right AI structures. We never had the ability to know that before. The folks at NYU are doing some really cool work in that space. And so then I think that's where you can really bring programmatic assessment and adaptive learning, together. And assessment doesn't just determine whether you've learned enough, it helps you determine what you should learn next. Coaching kind of course, embedded in the system, and everybody would have a coach. But then the goal is to gradually shift ownership. And early in training, the system might tell the learner, hey, here's what you need to work on. But later, you want the learner to be able to say, here's where my reasoning breaks down, and here's what I think is causing it, and here's what I'm going to go do to work on it. That's the master adaptive learner that we're trying to develop. And then layer in technology intentionally. So AI is going to make a lot of this so much more feasible, from data aggregation to teaching and learning. And it could create individualized, deliberate practice. And it could help identify patterns across really big amounts of assessment data that you used to have to pour through manually.
Right.
And it could prompt learners to explain their reasoning and reconnect clinical problems to the underlying basic science mechanisms, and help educators see where a learner may need additional practice. So I think ultimately technology would support the development of expertise, but it can't ever substitute for the cognitive work of building that expertise.
I think that's very well said. Very well said. So if you don't mind, I'm going to probe on two questions there.
Yeah.
So one, is it time-based anymore?
I think it's one of the challenges that we've all run into with competency-based education is the inability of our structures to allow for time variability.
Right.
The match, the fact that we need to enroll a certain number of learners every year into GME positions to keep our hospital system running.
Right.
And you can't offer an orientation 7 times a year and. So there are definitely some barriers, but I do think we're definitely seeing success with curriculum of different lengths. And I do actually believe that if you truly deliver on precision education, you're going to have some students ready to get through medical school in 2 years, and others are going to take 6, and that's okay.
Well, and maybe they need to take 6. I mean, you and I are moms, right? Like, would that have allowed us an opportunity to cut it down to part-time for a little bit, or ramp it back up when, before we had a baby or something? I mean, it's an interesting idea how that level of education might also integrate into somebody's unique personal home experience as well, and may really help people for whom that, even if the 4 years of schooling worked for them, the 4 years of being in school, 4 years of being in school may not have worked for them. And so it's an interesting idea too, in that you might be able to restructure it just simply to be better for everybody, to be able to lean into a health professions education without having to be quite so structured.
Yeah, and I think the other things that are, inherent structural barriers, our block clerkship model. When you think about trying to expose learners to, let's say, you've had plenty of practice in this context, but I actually need you to go have more practice in this context over here. That's sort of like mind-boggling, mind-blowing for us right now
Right.
to think about. But, as we are able to more definitively track gaps in a learner's knowledge, we also are going to need to develop systems that allow us to deploy learners in spaces where they're then going to be able to better fill those gaps, as opposed to just, well, over the course of the year, hopefully you'll see that.
Right. Yeah. And if not, do an aquifer case. No.
Yes, if not, do an
Kidding.
aquifer case.
Kidding.
Couldn't
help that one. Just couldn't help that one. But so here's another even more provocative question. Does this break down the barrier between any difference between being a medical student and being an intern and resident? Can we blend all of those together in your new reimagined system?
I don't think so, because I think we genuinely do need foundational expertise development. And I will say I still firmly believe that is the greatest risk to education of AI right now, is our learners. They're wonderful students, but they want the shortest pathway between point A and point B. And they do not appreciate that productive struggle is actually the key to learning. And so I think that's the message we have to be, sort of shouting from the rooftops, is that productive struggle is actually necessary to build the system, the architecture of your brain, on which ultimately clinical reasoning is going to happen, augmented by this wonderful AI tool. But you still have to have that underlying architecture before you get to play with this tool in the sandbox, or there's too much risk.
Yeah. Yeah, I love that. And I mean, to be fair to our learners, we didn't like productive struggle much either. No learner likes being a novice. But that being said, sorry, we can't wipe that one out with AI just yet. But I think your point, nor should we be doing that. And there are easy things that we can take away to make life better and easier, and we should be doing that. And other things that we should not be taking away. They are meant to be hard. Maybe there's some aspects of how hard it is that can be eased, but I think your point is well taken, that they just have to be hard. That's the point. So with that, let me just give you the last word here at the end. So in addition to hard things about learning, what hard questions do you think about the future of clinical education we're still not asking that need to be asked? You as your researcher, maybe some of the places you guys are going, or even maybe not asking ourselves honestly enough.
Well, I think you're starting to see a number of articles about this, which is like, what does it actually mean to be an expert clinician when some of the cognitive work that we've traditionally associated with expertise in our profession can actually be done by technology? We're asking a lot about how to incorporate AI into medical education, but maybe not enough about which capabilities physicians must still develop and maintain themselves, which means that we can then safely augment or offload tasks. And how are we going to know the difference? And then I think ultimately we need to decide not just how we educate physicians in an AI-enabled world, but what kind of physician that world requires.
Yeah. Yeah, well said. Well said. I think you're absolutely right. I think all of us are doing a little bit of inner soul searching to ask ourselves some of those questions after a career, or maybe midway through a career, in which those answers seem pretty straightforward, and all of a sudden they're not as well.
I mean, it's that compassion, the empathy, all of the other skills that are embodied with our reasoning that makes physicians the wonderful things that we are. And so how do we keep that?
Yeah, absolutely. Well said. Well, Michelle, with that, I think it's a wrap.
I just really want to thank you so much for just taking time out of your busy day, I'm sure, for being here with me and with people listening to this today. It's just been such a pleasure to finally get a chance to reconnect and hear how you're thinking and how you're really structuring everything you've worked on across your career into this, to this moment right now. And it's a new seminal moment, I think, for many of us, but you've given all of us a lot to think about. And I thank you for your time today.
Thank you.
Thank you for listening today. I hope we've left you inspired. For more on how Aquifer is moving health professions education forward, visit us at aquifer.org/clinical-learning-reimagined. Onwards and upwards.